Alterations in integument, pathophysiology and management. The skin is defined as an organ and it covers the body surfaces. It consists of two distinct layers, the epidermis and the dermis. The dermis, excuse me, the epidermis is the outermost layer that covers the dermis and is continually replaced every 35 to 45 days. It produces melanin, which is that dark pigment that helps determine the color of the skin. And that is stimulated by strong ultraviolet light, such as sunlight. The dermis is a strong connective tissue that contains elastic fibers, blood vessels, nerve endings, sweat and sebaceous glands, and hair roots. It also creates ridges which form a unique pattern of finger, palm, and footprints, and facilitates the ability to grip and hold objects. Subcutaneous tissue is skin that's attached to muscle, bone, and is made of connective tissue and fat cells. The hair is going to originate in the hair follicle in the dermis. There are two types of hair. We have vellus hair and terminal hair. Hair is composed of keratin and amino acids. Scalp hair is going to grow most rapidly, but all growth will start slowing by midlife. Decreased melanin production will cause graying hair as we get older. Sebaceous cells are connected to each hair follicle and they secrete sebum, which is an oily substance. This will help prevent the drying and cracking of hair and skin and is going to be more active during puberty. There are two types of sweat glands. We have the eccrine glands, which are going to release water and electrolytes in the form of perspiration, and apocrine glands, which produce cerumen, which perform no real purpose in humans. Nails are also formed from hard layers of keratin, and they also have a protective function. The nail root has an abundant capillary blood supply, and the lunula is the portion that is actively growing base. The skin performs its protective function by shielding underlying tissues from trauma and pathogens, and also by preventing excessive loss of fluids. It's going to help regulate temperature by altering the diameter of surface blood cells and through sweating. The body loses heat through radiation, conduction, evaporation, and convection. The skin has many sensory receptors for touch, pressure, pain, and temperature. Ultraviolet rays in sunlight will activate a substance in the skin that will eventually be converted into vitamin D. The skin contains an extensive blood vessel network that can store as much as 10% of the body's total blood volume. True or false? The epidermis is replaced with new cells every 35 to 45 days. The next layer, the dermis, contains the ridges that comprise the fingerprints. This is true. True or false? One of the primary functions of the skin is to protect underlying structures. This is also true. And true or false? Apocrine glands secrete fluid during perspiration. This is false. They secrete that substance in the external ear canals called cerumen. Regardless of the condition, it is important to perform a complete assessment. With our health history, we need to look at the medical diagnoses. It has to be obtained through the health history and a complete physical exam of the client. The chief complaint of and history of the present illness is also important. We're looking for discomfort, pruritus, which is itching, color changes, lesions, or any abnormality in the skin, hair loss, or abnormal hair growth. We're looking at the onset of the condition or the precipitating or alleviating factors. We look at the medical history. Is there any previously diagnosed skin disease or problem, current or recent medications and allergies? Do they have a history of diabetes mellitus, cancer, kidney failure, thyroid disease, liver disease, or anemia? We review the systems. Is there a change in skin color or pigmentation? Do we have a change in a mole? Do we have sores that are slow to heal? The itching or pruritus, dryness or scaliness, excessive bruising, rashes, lesions, hair loss, unusual hair growth, or changes in the nails. We also look at the functional assessment. What are their past and present occupations? This would include exposure to chemicals or other irritants, skincare habits, and sun exposure. Are there recent changes in the work or living environment? And what are their current stresses and sources of anxiety? Because we know that this can affect skin. We need to do a nutritional assessment and determine the nutritional status by questioning the client about their intake. We can also obtain some labs, such as albumin, which is protein, prealbumin, creatinine kinase, creatinine, myoglobin, and potassium. We know that vitamin A is required for healthy skin, and we can get this from liver, avocados, pumpkins, sweet potatoes, carrots, spinach, broccoli, cantaloupe, and apricots. Poor nutrition or fluid intake, we might see cracked skin, dermatitis, dry skin, purpura, which are those purple splotches on the skin, petechiae, those little tiny pinpoint bruises, poor wound healing. Wound healing may require a high calorie, high protein diet or enteral nutrition, which is the nutrition that goes into the stomach through a tube, or nutritional supplements. Physical assessment will require adequate lighting. We're assessing for smoothness, coloration, intactness, temperature, and hydration of the skin. Skin should be free of lesions. We assess the hair for color, distribution, and texture. We're observing for abnormal findings such as nits, lice, scaliness, or flakiness. We're assessing nails for normal structure, variations in the shape, thickness, the color of the nail bed, and capillary refill. There's four main descriptions for skin color. We're talking pallor. Pallor means the skin is pale or white. In brown-skinned people, this might be more of a yellowish brown. And in black-skinned people, this might be more of an ashen color. We may need to observe coloration in the mucous membranes, the lips, or the nail beds if we have a dark skin color. Erythema is defined as being a pinkish or reddish color. Cyanosis, we have a blue color. Jaundice is a golden or orange-yellow color. So let's talk about assessing a wound. You have to use your senses when you assess a wound. What does it look like? We're looking at the color, the swelling, the exudate, which is the drainage. Is it warm to touch? Is it soft? Is it boggy? Meaning, is it kind of squishy when you touch it? Is it firm? Etc. Does it have an odor? And we determine odor by cleansing the wound first. If there's no odor following cleansing, then the wound has no odor. Do not determine odor from an old dressing. It's going to have an odor. Listen for complaints such as moaning or groaning. The client catches their breath or something else to help assess pain. When we measure the wound, we are measuring it like the face of a clock. The client's head is always 12 o'clock. The feet are always 6 o'clock. The nurse's right will be 3 o'clock. The nurse's left will be 9 o'clock. Then describe the areas of the wound according to the clock face. Let's say we have redness at 12 o'clock, but we have a dark brown leathery appearance at 6 o'clock. That's how we would describe it. Up and down is always going to be the length, and we list that first. Side to side is always the width. So again, we're talking 12 to 6 o'clock is always the length. 9 to 3 o'clock or 3 to 9 is always going to be the width. Then we measure the deepest point of the wound. We place the tip of a cotton applicator into the wound base. We lay our thumbnail along the edges of the wound and mark that cotton applicator with our thumbnail. Then we pick it up, keeping our thumbnail in place on that cotton applicator, and measure it on our ruler. Wounds are always measured in centimeters. And by the way, the depth will be the third measurement. You are always going to have a depth if you have an open wound. It will always be at least 0.1 millimeters. Then we need to look at undermining and tunneling. We're looking at the edges of the wound. The edges of the wound, we hope, are always going to be attached to the wound base. So the base of the wound, there's no loose edges, in other words. Those loose edges would be undermining. So we're going to take our cotton-tipped applicator and we're going to run it around the edges of the wound to see if that applicator actually goes underneath the edges of the wound. If it does, we have undermining. And then we're going to document it. Let's say we have undermining from 1 o'clock to 3 o'clock. Always go clockwise, never go counterclockwise. Because if you say you have undermining from 3 o'clock to 1 o'clock, that means you have undermining around most of the wound. Whereas if you say you have undermining from 1 o'clock to 3 o'clock, then you have undermining just between the 1 and the 3, and it's a much smaller area. Then we look at tunneling. Tunneling is going to be basically a tunnel in part of the wound bed. Again, we're going to determine undermining and tunneling by putting it in the deepest part, put our thumbnail up against the cotton-tipped applicator while it's inserted into the deepest part, pull it out with your thumbnail still in place, and then measure on your ruler. The wound bed base is going to be determined by 4 different types of wound bed tissue. We have epithelial. Epithelial skin is a partial thickness skin loss. It is the only type of tissue that you will see with partial thickness. This is where the skin is just nice and pink, more of a light pink color. Think about just getting a light scrape on your skin where it breaks the skin. Okay, that's going to be your epithelial tissue. Granulation tissue is going to be that full thickness skin loss. It's going to be beefy red. It's going to be that dark pink or red color. This is nice, healthy tissue, and epithelial tissue is nice, healthy tissue. Then we get into our unhealthy tissue or our dead tissue. This would be slough. Slough is going to be from a full thickness skin loss, but this tissue is non-viable. Again, it's dead. It's going to have a yellow, white, or tan appearance. It's usually pretty moist. It looks like snot or pus on the wound bed, but you can't wipe it away. It adheres to the wound bed itself. Then we also have eschar. Eschar is also going to be indicative of a full thickness skin loss. Usually it's going to be black in color or dark brown. It might be hard and dry, or it might be soft and moist. Might look kind of leathery. It may also kind of look like a scab, but it's not really a scab. If the slough and or eschar are removed, then we would have that granulation tissue underneath it. So when we're assessing our wound, the next thing after assessing the wound bed is to assess the peri-wound. The peri-wound is going to be the area around the wound. We're going to assess up to 4 centimeters around the perimeter of the wound. We're looking at the skin integrity. Is it nice and intact? What color is it? Do we have any what we call induration? Induration, if you're palpating, is going to be kind of a firmness underneath the skin that we're able to palpate. Is there any warmth? That warmth would indicate potential infectious process going on. We're assessing for edema or erythema, the induration, and the warmth. Something we sometimes may see if a wound is really wet, excuse me, would be what we call maceration. Picture getting into the bathtub or the swimming pool, and you stay in there for a long period of time. And when you get out, the skin is kind of white colored. That's maceration. So it's a real moist skin and it's easily damaged. It's very fragile tissue. Then we move on to the exudate or the drainage. We're assessing for the type of exudate, the amount of exudate, and the odor. Once again, remember that you have to clean the wound before you assess for odor. So we have basically 4 different types of exudate. We have serous, which is going to be clear or light yellow. So basically, let's say you have a fluid-filled blister. If you pop that blister, the fluid that comes out of it is kind of a clear or yellow color. That would be serous. Sanguinous is going to be pure blood, straight blood. Serosanguinous is going to be a mixture of serous and sanguinous, or serous and blood. It could be a watery blood, or it may just be a blood tinged, a light pink color. That would be serosanguinous. Purulent is going to be pus-filled or opaque. We could also potentially have a mixture of sanguinous and purulence at the same time. We should assess the wound for signs of infection. Again, this is going to include erythema, warmth, purulent exudate, edema, and increased pain. And again, we always assess for pain. Is the client verbalizing pain? Can they rate it on a numerical scale? Are they just moaning or groaning? Are they crying or yelling? What's their body language? Is there any grimacing, withdrawing, or guarding, where they kind of put their hands over the wound to keep you from touching it? We also look at skin tears. Skin tears are traumatic wounds that are caused by mechanical forces. This would include a removal of an adhesive. Um, we get our definition from the International Skin Tear Advisory Panel. There's also several classification systems of skin tears out there, and those classification systems provide continuity to our wound descriptions. I kind of like that new simplified International Skin Tear Advisory Panel skin tear classification. It only has 3 types, and to me, easiest is best. With the type 1, there's no loss of the skin. There might be a linear or flap tear that can be repositioned to cover the entire wound bed. A type 2 skin tear is going to be a partial skin loss, where we have a partial loss of the flap that cannot be repositioned to cover the wound bed. And if you look at the slide, this is what we would consider to be a type 2 skin tear. A type 3 would be a total flap loss, where the entire flap is gone and the entire wound bed is exposed. ISTAP also states that a flap in skin tears is defined as a portion of the skin. It can be epidermis or dermis that is unintentionally separated from its original place due to shear, friction, and/or blunt force. Skin tears are very common in the older adult because they have a loss of skin elasticity. They can occur on any part of the body, usually the arms and the legs. Again, particularly common in populations that have fragile skin, especially the elderly. This could also include the chronic or critically ill, neonates, and our pediatric clients. We prevent skin tears by creating a safe environment for the individual that's going to minimize the potential of bumping or knocking into furniture. When possible, we should pat and protect the extremities if they're at high risk for skin tears. We maintain skin integrity through consistent skincare regimens and proper nutrition and fluid intake. Clients should always wear protective footwear and clothing to help reduce the risk of injury. We should also ensure safe patient handling techniques that are going to limit the risk of injury. Sometimes just grabbing a client around the arm, if their skin is fragile enough, can actually create a skin tear. And we should avoid the use of adhesive products on frail skin, because you can remove that adhesive and pull the skin up with it. We treat it with the main goal of preserving that skin flap if possible. and protecting the surrounding tissue. We can reapproximate the edges without undue stretching. We do that by using a moistened cotton-tipped applicator. Protect the site to reduce the risk of infection and further injury. When we select a dressing to use on a skin tear, we look for a dressing or medical adhesive that's going to allow for atraumatic removal. In other words, we're not going to traumatize the skin any further. We want extended wear time of the dressing and moist wound healing. If the dressing is opaque, in other words, you don't see through it, use an arrow on the dressing to indicate which direction the dressing should be removed so we don't disturb that skin flap. And monitor the wound for signs of infection such as pain, increased exudate, swelling, heat, erythema, and odor. These are pictures of the different skin types. If you look in the upper left, this is nice pink tissue, especially along the lower half. This is epithelial tissue. If you do look at the top part of that wound, that's going to be more granulation. That becomes your beefy red. It looks like hamburger. The upper middle, this is pretty much 100% granulation tissue. The upper right, this is slough. It's that adherent, moist, light yellow tan tissue, but it's dead tissue. If you look at the lower left, this is what we call eschar. It has that scab-like appearance, but it's not really a scab. It's leathery, it can be dark black or brown, it can be dry, or it could be moist. And then in the lower right, this is what we call a deep tissue injury. Usually this will be found over a bony prominence, and if you look at this picture, this is located on the heel, so we consider that to be a pressure point. That tissue is injured deep inside, so if that were to open up, we would have a full thickness injury. So remember, once again, epithelial is going to be partial thickness. All of the others are full thickness injuries. Different diagnostic tests are available out there. Visual inspection is going to be the primary method of diagnosis, and it may require culture and sensitivity tests if we suspect that there's bacteria in the wound, and allergy tests to determine sensitivity to one or more allergens. We can use a Woods light, which consists of a black light, to identify certain fungal infections. Potassium hydroxide tests can also identify fungal infections that we don't observe with the Woods light. A fungal culture can determine the type of fungus that causes an infection. A skin biopsy will remove tissue for microscopic examination. There's three main methods of biopsy. We can just scrape a lesion with a scalpel or a razor to remove a layer of tissue. We can excise a lesion, either partially or completely, with scissors or a scalpel. Or we can use a punching instrument where we center that over the middle of the lesion and we get part of the core of the lesion. Many treatments that are available. There's drug therapy. There's a multitude of medications that can be applied topically or be administered systemically. We should always use a sterile glove to apply topical medications if it's over an open wound. If it's not an open wound, then just use a clean glove. Again, standard precautions have to be observed. We can use dressings. They should protect the wound and retain surface moisture. Excuse me. We have different types of dressings. This can include wet dressings, dry dressings, absorptive dressings, and occlusive dressings. The key to choosing a dressing is selecting a dressing that has to be changed as infrequently as possible. The longer it can stay on, the better. Usually 3 to 5 days is preferred. And if the wound is wet, we want to dry it out. And if the wound is dry, we want to add moisture until we reach that perfect moisture balance. Keeping a wound moist is going to hasten the healing. We can also do negative pressure wound therapy. We refer to this as a wound vac. This can reduce the healing time of traumatic wounds, the dehisced or opened surgical wounds, pressure and chronic ulcers, and it also can help manage wounds with heavy drainage. We can do therapeutic baths. These are not soaps, but they may have various medications put into the water, such as oatmeal or cornstarch or baking soda, occasionally mineral oil, but we need to be very cautious with putting oil into the bath because this creates a severe safety risk. These therapeutic baths can provide inflammation and itching relief and aid in the removal of crusts and scales. We can treat by doing surgical incision to remove the skin lesions by using laser therapy that uh, uses special rays, and it's very important to protect the eyes and take measures to prevent fires and burns. Cryosurgery applies sub-freezing cold to a lesion, and electrodesiccation will use electrical energy to help remove superficial lesions. Radiation therapy can be used to treat malignant skin lesions. Photochemotherapy will use ultraviolet light and chemicals to help destroy cells. We also know that lifestyle changes can improve some skin conditions. Tiredness or emotional stress can aggravate skin conditions. Rest, sleep, and diet are important factors in treatment. And nutrition should include small, frequent meals to increase that caloric intake. Increased protein will help promote healing, whether we have a wound or the client is ill. And enteral feedings if the client is unable to take in appropriate nutrition. Protein supplements and vitamin A, C, and zinc may also be required to promote healing. So again, if it's wet, dry it out. If it's dry, get it wet. It's also important to be familiar with the age-related changes. Changes in the skin are probably the most readily recognized of all signs of physical aging. Wrinkling will be the result of thinning skin layers and the degeneration of those elastin fibers. We're losing that elasticity. Sweat glands will decrease, but production doesn't change much until we're advanced in age. Sebum production, that oily production, will also decrease, and that will be apparent in women at an earlier age than in men. Dryness and pruritus are very common. The skin is going to start paling due to the decrease in the number of cells that produce melanin. Skin lesions are also going to be more common in the older adult. We have those lentigines or those liver spots on exposed skin, and you see that in the top picture. Senile purpura, those dark purple bruises or discoloration that come from minimal trauma, and it takes forever for them to go away. Senile angiomas are going to be bright red spots on the skin of the older adult. Seborrheic keratoses are lesions that vary in size, and they can be flat or raised. And if you look at the middle picture, these are what seborrheic keratoses look like. And then acrocordons, or skin tags, and that would be the lower picture. By the age of 50, nearly half of older adults are going to have some gray hair. Men may begin to lose their hair from the scalp in their 40s, but by their 80s, many of them are almost bald. Women often have thinning hair. They don't necessarily go bald, but their hair becomes thinner. And women are also going to have an increase in the growth of facial hair, especially around their chin and around their upper lip. But all older adults are going to start having increased hair in the nares. They're going to grow a different type of hair from the eyebrows or coming out of the helix of the ear. Fingernails and toenails are going to start flattening. They're going to become dry and brittle and may become discolored. And the risk of premalignant and malignant skin lesions are also going to increase with age. And now your post-test.